We talk about kidneys remove toxins. Remove toxins. The structural and functional unit of the kidney is called the nephron. We have a million nephrons. Each individual nephron filters millions of little filters in our two kidneys. And as filtering, it takes very into urine is what we're really going to be focusing on in a lot of detail today. Big idea is filtrate. I'm really just summarize in excruciating detail. Concentrates in urine. We'll talk about it in a lot more detail. To move from our filtrate, we are going to use two key things. We're going to use the osmosis of water, and then we're also going to use active transport. Some of this active transport will be active transport of the water directly, and sometimes we'll have active transport of ions which power a concentration gradient to cause the water to move. Concentration gradient is going to be made of dissolved electrically charged ions, dissolved electrolytes, and this can be referred to as a salinity gradient as we look at this. So the salinity gradient is going to increase as we go deep into the medulla. So we have renal cortex. I'm going to put RC up on top for renal cortex. I'll put RM on the bottom for the renal medulla. So as we go from the cortex down into the medulla, the osmolarity, and I really wish there were units on this figure from your textbook, the osmolarity of the extracellular fluid increases. And that increase in extracellular osmolarity causes more water to be pulled out of the filtrate as the filtrate is going through the descending limb of the loop of Henle, or nephron loop. So as we're looking at this nephron loop, we have the descending limb, and in that descending limb, which is a thin segment, we have water going out into the extracellular fluid. The ascending limb, which is over here, is the thick segment. So when we think thick segment, I want you to think ascending limb. This is the part where the filtrate goes up the loop of Henle, nephron loop. And during this process, we're going to be pulling electrolytes actively out of the filtrate. So on the way up, osmosis, on the way up, we pull electrolytes out through active transport. And this is going to do two things. First, it's going to maintain the salinity gradient. That gradient that I highlighted earlier, let's clear the slide. So that salinity gradient as we go down. We pull the water out first, and then we pull so we have water going out. The water dilutes the salinity gradient, but then we add more sodium chloride to reestablish the salinity gradient. So that salinity gradient is preserved. Second thing that happens here is, slide again, let's look at the filtrate's osmolarity. The filtrate becomes more concentrated as it goes down deeper into the salinity gradient. So the osmolarity of the filtrate increases as the osmolarity of the extracellular fluid increases. And then, as the filtrate is going up the ascending limb, and we're pulling the electrolytes out of the filtrate becomes more dilute. We go from 1,000 millimolars or milliosmolar to 500 milliosmolar to 100 milliosmolar. So that concentration of the filtrate becomes reduced. So we have dilute filtrate. We have relatively dilute filtrate out. The amount of greater than the capacity of the nephron. So after our nephron loop, or loop, water. We're looking at about 20% of the water. It's going to be removed from our filtrate. It's going to be removed from the distal tubule. So with the dissolved salts, the dissolved items that we want to reclaim through tubular reabsorption. We're looking at we would have about 6 liters of liquid exiting the nephron. So we still have to process it quite a bit. We want to get up in the disconvoluted tubule and collecting duct. Change tactics. Beforehand, we have supply present in the proximal within the nephron loop, and within the distal convoluted tubule and the collecting duct, we're going to focus on hormonal control now. This is where we can have a lot of fine-tuning, fine regulation. Primary cell types in our distal convoluted tubules, we're going to focus on the principal cells and the intercalated cells. Principal cells are going to focus salt and water around. Today, we're going to focus mostly on principal cells. We're going to spend a good amount of time talking about the kidneys. Principal cell. This principal cell is showing sodium ions. To the cell, ultimately goes to water to go back to the blood. Aldosterone is one that I've already talked about, the renin-angiotensin-aldosterone system. This is the third time in this class during lecture we've talked about aldosterone. We'll also talk about it again on Thursday because it's an important hormone for regulating fluid balances and electrolyte balances in our bodies. So when we think about aldosterone, I want you to think of it as a salt-retaining hormone. And I mean this in the colloquial sense of the term. It's going to help us to retain sodium ions and, to a lesser degree, chloride ions. We get the not salt ion retaining hormone, but chloride retaining hormone more than anything else. When we look at there are a couple ways we get it released into our bodies. The we talked about already and renin, the blood stream, it helps one goes exposed to ACE from the kidneys and lungs, angiotensin 2 is going to stimulate the adrenal cortex to release aldosterone. And while we have aldosterone in our bloodstream, it goes to the distal convoluted tubule and triggers absorption and triggers potassium ion excretion. So, on the thick segment of the nephron loop, so the ascending portion of the nephron loop, the distal convoluted tubule, and the first part of the collecting duct. When we say the cortical portion of the collecting duct, that's the portion of the collecting duct in the renal cortex, not the portion in the renal medulla. So those are the parts of the nephron that aldosterone acts on. And while it's acting on those parts of the nephron, I'll say it again, we have sodium reabsorption. So sodium leaves the filtrate and ultimately goes back to the bloodstream. And that potassium. So ultimately, potassium leaves the bloodstream and goes into the filtrate, that forming urine. Pragmatically speaking, this means that when we're exposed to aldosterone, we urinate out a whole bunch of potassium. And when we look at these ions, we have a +1 cation, we have a +1 cation here. So we're exchanging +1 ions with each other, so we can still maintain the resting membrane potential of all the cells involved here. So as we have sodium ions be reabsorbed from the filtrate, that changes osmolarity of the extracellular fluid and the blood plasma, or the blood. That's going to cause water to follow the chloride ion as well, due to the electrical attraction of chloride, in particular sodium. So ultimately, when we have aldosterone exposed to our kidneys, we have water removed from the filtrate and we have sodium chloride removed from the filtrate. And our urine volume goes down, blood volume goes up, and blood pressure goes up. in addition to having more potassium dumped into our urine. We also have ADH, antidiuretic hormone, and again, this is like the fourth time in the course sequence I've mentioned this one. It's a big player in the kidneys. Unlike aldosterone, ADH is going to focus primarily on the water directly. ADH is one of the two hormones I asked you to learn, are secreted from the posterior pituitary gland. Travel to the kidneys when we're exposed to dehydration, blood loss. Maybe we have an increase in blood osmolarity. All these situations are associated with not enough water in the blood. So if we don't have enough water in the blood, we will release ADH, and ADH causes us to reclaim more water from our filtrate. In particular, ADH is going to act on the collecting duct. And within the collecting duct, ADH causes us to reabsorb water. It upregulates the expression of a protein that forms aquaporins, or water holes, within the collecting duct. We also have natriuretic peptides. Sometimes I've heard these referred to as atrial natriuretic peptides as well. Your text sticks with the term just natriuretic peptides. And when we look at these natriuretic peptides, or the formerly atrial natriuretic peptides, they're released from the atria of the heart. And they're going to be released from the atria of the heart in response to high blood pressure. So aldosterone and ADH are released in response to low blood pressure. The aldosterone and ADH cause blood volume to go up and blood pressure to go down. Here's a hormone that does the opposite. It causes blood volume to go down and blood pressure to go down. We need to have a way to lower blood pressure in addition to a way to raise our blood pressure. So when we look at these natriuretic peptides, they're going to cause an uptick in urine formation. So we're going to urinate out more water to ultimately lower our blood pressure. And in order to urinate out more water, our afferent arteriole that's sending blood into the glomerulus, that capillary bed of the renal corpuscle, is going to dilate. So we'll send more blood into the glomerulus. We have more blood going into the glomerulus. That is going to increase the amount of filtrate produced. Atrial natriuretic peptides also are going to cause vasoconstriction of the efferent arteriole. So the dilation of the arteriole that delivers blood, paired with the constriction of the arteriole that removes, causes there to be much higher pressure in the glomerular capillaries. And a dramatic increase in blood pressure in the glomerular capillaries causes a dramatic increase in the glomerular filtration rates, or just a lot of liquid being removed from the blood. Something else that peptides do is they inhibit aldosterone secretion and renin secretion. So this natriuretic peptide is going to slow down or inhibit the renin-angiotensin-aldosterone system. It's also going to inhibit the secretion of antidiuretic hormone, and it's also going to inhibit the direct absorption of sodium chloride. So it works multiple ways. Not only does it make it so that we produce more filtrate, it also downregulates the mechanisms we have that serve fluid. Ultimately, natriuretic peptides are going to cause the urine to become more dilute as we dump more liquid into the urine and pull that water from our bloodstream. And then we have parathyroid hormone, PTH, another one that we talked about. And when we talked about PTH last semester with the endocrine system, we just mentioned it as that hormone that helps us to reabsorb calcium. And it still is that hormone that helps increase blood calcium levels. But in the urinary system, we're going to focus in particular, not on the osteoblasts and osteoclasts, we're going to focus on the urine and how we lose calcium from our body in our urines. Low blood calcium is known as hypocalcemia, and we release PTH, parathyroid hormone, in response to that low blood calcium. Parathyroid hormone is going to travel to the proximal convoluted tubule, and within the proximal convoluted tubule, we'll have more phosphate ions excreted into the urine, or excuse me, into the filtrate. It's not quite urine yet. For those of you who don't remember, a phosphate is one phosphorus oxygens, and it has a 3 negative charge. Your textbook, though, calls this typically inorganic phosphate. It'll have a P with a lowercase I next to it. But I think that's a bad abbreviation. I like the chemical formulas. So we're going to dump more phosphates into our urine. And as we're dumping more phosphates into our urine, or at this point, filtrate, the phosphate that's present in the filtrate and ultimately present in the urine makes it more difficult for us to keep the calcium present. So if we have more phosphate entering the filtrate, we will ultimately have more calcium reabsorbed from the filtrate in the distal convoluted tubule and the thick segment of the nephron loop. Something else is going to happen here as we're looking at this process. Parathyroid hormone is going to be used for vitamin D3 synthesis. The formal name of vitamin D3 is calcitrol. And as we're synthesizing vitamin D3 in our kidneys, that vitamin D3 will be reabsorbed into the bloodstream to the intestinal tract and make us absorb more calcium ions from the lumen of the small intestines. So not only does parathyroid hormone make it so that we have more calcium in our blood from the urine, we're also going to upregulate the amount of calcium in our blood from the intestinal tract as well, indirectly because parathyroid hormone causes the synthesis of calcitrol. So we've talked about the nephron loop. We've talked about the distal convoluted tubule. Let's talk about the collecting duct. When we look at the collecting duct, more than anything else, I want you to focus on movement of water. There's going to be a little bit of processing of ions, a little tiny bit of metabolite reabsorption or secretion in the collecting duct. But the big key idea here is that at the collecting duct, we remove lots of water from the filtrate. This is the final stage where we concentrate that filtrate to make it into urine. So as we look at the collecting duct, it's that last portion. Sometimes we include it with the nephron, but the truth of the matter is there will be multiple nephrons for one collecting duct, or we'll have multiple distal convoluted tubules all merging to form one collecting duct. So if I clear the screen here, we can have distal convoluted tubule there. There's one right here. There's another one shown right there. There's another distal convoluted tubule shown right there. So multiple distal convoluted tubules will merge together within one collecting duct. And when we're looking at that collecting duct, it's going to go through that salt gradient. So we already sent the filtrate through the nephron loop, and it was exposed to that saline gradient as it was going through the medulla. We have that same saline gradient again. So, and as the filtrate is going to a more and more hypertonic extracellular environment, more and more water molecules will be selectively removed from that filtrate via diffusion. Ultimately, when we get to the end, the filtrate, or that tubular fluid, has gone from about 300 milliosmolar to approximately 1,200 milliosmolars. In other words, we've about quadrupled the concentration of the filtrate to make it into urine. Or another way to think of it is that we remove about 75% of the water from the filtrate that enters the collecting duct. When we're looking at the collecting duct works in conjunction with the nephron loop and some of the capillary beds we've talked about earlier to form something known as the CounterCurrent Multiplier. The CounterCurrent Multiplier is a way for us to preserve the saline gradient, or this salt gradient in the medulla. And it's a way for us to constantly remove fluid from the filtrate. So we call it a CounterCurrent multiplier for two reasons. It's a multiplier because we're going to recapture the salt. We'll have a little bit of salt enter into the filtrate as we are moving the filtrate through the nephron. And that salt that enters the filtrate ultimately is going to be removed from the filtrate to go back into the medulla. That will preserve the saline gradient of the medulla. And then it's countercurrent because fluids are flowing in opposite directions. We'll have the descending limb of the nephron and the ascending limb of the nephron having filtrate move counter to each other or opposite of each other in terms of the direction of travel. So let's focus on first the downward flowing filtrate of the descending limb. As that liquid is going down through the descending limb of the nephron, it's going to be exposed to ever-increasing saline gradients in the renal medulla. Those increasing saline gradients ultimately are going to cause lots of water to diffuse out of the descending limb. This descending limb is the thin segment. It doesn't have a simple cuboidal epithelium. It has a simple squamous epithelium. And the simple squamous epithelium of the descending limb makes it so that water can just travel across the membrane very quickly, very rapidly, and we have a concentrating of the filtrate. As that water goes from the renal the tubule into the extracellular fluid, that filtrate becomes a lot more concentrated at the deepest portion of the nephron loop. After that deep portion of the nephron loop, the descending limb, we have the ascending limb where the filtrate's traveling up again. And as that filtrate is traveling up towards the distal convoluted tubule, we're going to shift cell epithelium. So we'll go from a simple squamous to a simple cuboidal epithelium. The simple cuboidal epithelium, or the thick segment of the ascending loop, is impermeable to water. Water has a very difficult time traveling across that simple cuboidal epithelium. However, we're going to have active transporters and some passive transporters as well that are going to be moving those three key electrolytes: sodium, potassium, and chloride electrolytes. And all of those electrolytes are going to be dumped back into the extracellular fluid. So at that base, the deepest portion of the nephron loop, with highly concentrated filtrate, but then as the filtrate goes back up again, we're going to remove the ions from the filtrate and reestablish our saline gradient. So to paraphrase, we have dilute filtrate entering the nephron loop. As the filtrate goes down, water is pulled out and it becomes really concentrated at the bottom. And then as the filtrate starts to go up again, we start pulling the electrolytes out to go from super concentrated filtrate to very dilute filtrate that enters the distal convoluted tubule. So first we remove water, then we remove ions from the filtrate, and we preserve the saline gradient of the medulla. There's another aspect of this countercurrent system, and or the countercurrent multiplier, and that is urea. Urea is one of the nitrogenous wastes that sometimes will add to the filtrate through tubular secretion. Sometimes we'll remove it from the filtrate through tubular resorption. It depends on our homeostatic balance of urea. We need a little bit of urea in our bloodstream to be used to synthesize amino acids for the non-essential amino acids of our diet. And as we're looking at the urea, we generally speaking will have a relatively high concentration of urea in the extracellular fluid deep in the medulla of the kidney. And that urea is going to be cycled back and forth from the collecting duct to the deep portion of the nephron loop. I'm going to skip ahead a couple of slides here. I want to show you the picture while we're talking about urea. So if we look here, we can see urea that's leaving, and I know you can't read this on the screen up in front, but trust me, this is the diagram that shows urea leaving the leaving collecting duct. That urea will then re-enter into the thin segment of the nephron loop. So the Urea exits the filtrate in the collecting duct and then enters the filtrate in the nephron loop. And this recycling of urea helps to maintain and establish those concentration gradients. So in addition to the sodium, potassium, and chloride ions maintaining the concentration gradient of the medulla, we're also going to have urea in the medulla constantly being recycled and maintaining our concentration gradients. So that urea, just to reemphasize, leaves the collecting duct and then will re-enter the medulla, increasing the osmolarity of the medulla. As we have an increase in osmolarity of the medulla with urea, urea will enter into the nephron loop and be transported back to the collecting duct where it's pulled from the collecting duct again. So we recycle the urea continually. So let's pause for a moment and have a review question. We have some hormones. I'd like you to match the hormone with the function and talk amongst yourselves. We have 4 hormones. We have 4 functions. The best for each hormone. It looks like we need a little bit more time. I'll give you another 45 seconds. So go ahead and match the hormones with the function. We're down to about 15 seconds. Make sure you get an answer submitted. For 5 seconds, please submit your answers. So as we're looking at our answers here, looks like about 113 of us nailed it. When we think of aldosterone, I want you to think of sodium reabsorption. Having sodium absorbed is going to cause more water to follow, and having water follow raises blood volume and ultimately blood pressure. When we think of ADH, I want you to think of reabsorbing water directly. The water increases blood volume and ultimately increases blood pressure. P for the nature of peptides. Instead of raising blood volume and blood pressure, they lower blood volume and blood pressure. So these peptides are going to make it so that we have more liquid entering the filtrate, and we'll have more dilute urine and decreased blood volume, decreased blood pressure. And when we think of parathyroid hormone, that causes blood calcium levels to go up as we have blood urinary phosphate levels increase at the same time. So, back to the countercurrent system. As we're looking at these capillaries of the nephron, we have the peritubular capillaries, which are associated with the cortical nephrons, and we have the vasorecta capillary bed, which is associated with the juxtamedullary nephron. These capillary beds are important for the countercurrent system because we're going to be adding or subtracting things from these capillaries through renal secretion and absorption. In particular, when we look at the vasorecta, this is a capillary bed that's deep into the medulla. So this vasorecta capillary bed is going to spend a lot of time regulating fluid volumes particularly with the juxtamedullary nephrons. In addition to having a countercurrent system with the nephron loop, where the filtrate flows in opposite directions, we also have a countercurrent system with a blood flow within the capillaries of the vasa recta. Let me skip ahead a slide here. So the blood flows one direction going down, another direction going up, and the capillary bed of the vasa recta is going to have those capillaries side by side. So we have another countercurrent flow here. We have countercurrent flow in the nephron loop, and we have countercurrent flow of the blood of the vasa recta. And the blood is going deeper into the medulla as it's traveling through the vasa recta capillary bed. It's going to be exposed to ever increasing salt concentrations. We have that saline gradient of the medulla. And that blood will absorb salt because the blood will be hypotonic relative to the extracellular fluid of the medulla. And then as our blood is exposed to that highly saline, that hypertonic extracellular fluid, we'll also have water leaving the blood during the descending limb, or descending trip. So ultimately, with that descending limb of the vasa recta, we have water added to the bloodstream, and, water leaves the bloodstream, and salt is added to the bloodstream. That can be illustrated in this figure from your textbook, where on the descending limb, water is going out, and we have sodium chloride going in. Ultimately, if we're going to subtract water and add dissolved electrolytes, what we find is that there's going to be a dramatic increase in the osmolarity of the blood plasma in this descending limb of the vasa recta capillary bed. And then as the blood changes directions and now is going through the ascending limb back to the renal cortex, that blood is going to be exposed to a decreasing saline gradient. And as the blood is exposed to the decreasing saline gradient, we'll have the opposite occur. Water enters the bloodstream, and salts, sodium and chlorine ions, exit bloodstream. This ultimately can be considered a form of recycling. We have water go in at one branch and water go out on the opposite branch. And then this reverse is true for the sodium and chlorine. We have sodium chloride going in during the descending branch, and then sodium chloride going out with the ascending branch. So this exchange, this recycling of both water, sodium, and chlorine ions allows for us to maintain that saline gradient. It's just yet another way we maintain the gradient that powers the concentration of our filtrate into urine. So we could take all of these ions, all of these chemicals that we've talked about, and really just summarize it on this figure. And if we look at this figure, we can even summarize it even more and just say we concentrate filtrate to make urine. Ultimately, that's the goal here. Now, when we look at the renal corpuscle, we have incredibly dilute filtrate in that renal corpuscle, and we have a lot of really good, really beneficial molecules that make it into the filtrate. We have amino acids, we have monosaccharides, we have nitrogenous waste that we recycle to make amino acids, and in the proximal convoluted tubule, we reabsorb, with tubular reabsorption, many of the important organic and inorganic molecules or ions that we want in our bloodstream to help maintain homeostasis. One of the reasons why we have such an incredible amount of reabsorption in that proximal convoluted tubule is it has an incredible surface area. Not only is it much longer than the distal convoluted tubule, but the proximal convoluted tubule has the microvilli in it, and the proximal convoluted tubule does not have any microvilli. So we have physically a longer length, and then we also have that increased surface area from the microvilli, which allows for us to have a lot of tubular reabsorption in the proximal convoluted tubule. We'll have a little bit of tubular secretion as well, with some nitrogenous wastes entering into that proximal convoluted tubule. Then we have the nephron loop, which we started up on today. The big idea behind the nephron loop is that water is removed from the filtrate, urea is added to the filtrate, and then sodium, chlorine, and potassium ions are removed from the filtrate as well, depending if we're on the thick or thin segments of the nephron loop. And then we're at the distal convoluted tubule. At the distal convoluted tubule, we're going to have some cells that help to regulate pH balance. We'll talk about those on Thursday. We're also going to have cells that help to regulate ion concentrations as well. So we reabsorb the sodium and the potassium ions, in particular when we're exposed to aldosterone. We'll also have reabsorption of water molecules when we're exposed to aldosterone or antidiuretic hormone. We'll talk about the bicarbonate ion on Thursday when we get to pH balance. And then finally, within the collecting duct, we remove lots of water from the filtrate. And this is where lots of the concentrating of the filtrate occurs to make the urine. And then we also have that urea that we recycle. So just to review the urea again, urea leaves the filtrate in the collecting duct and then enters the filtrate in the thickened segment of the nephron loop to help maintain that saline gradient so it can remove as much water as possible from each segment of the nephron loop. Or, to paraphrase again, we remove water, concentrate the filtrate, and make urine. So now we've made urine. Now what? Well, we don't want to be urinating constantly. Constant, continual urination is not good for us. If we're always urinating, we're going to have a lot of irritation, a lot of irritation of the epidermis of our skin. Urine, in most situations, is mildly acidic. And if you spend too much time in diapers, you know that a kid sits in a wet diaper for a long period, a couple hours, they get a diaper rash. Urine is mildly caustic to the skin. So we don't want a continual dripping of urine out of our bodies. We need some way to store it for a little bit and then get rid of it when it's convenient. So now we're going to talk about how we store and release the urine now we've made the urine. The term that describes this is episodic. And I've never actually seen anyone use the term episodic outside in everyday speech. The idea behind this is that we have a distinct event. There's an episode where we pee on the toilet, and then we're done. So there's a point in time where we get rid of the urine, and then we store it again and build up the volume of urine in our bodies. We have a very nice storage apparatus, our urinary bladder, and we also are going to have some controls, both autonomic and voluntary controls, to help us regulate urine release, this episodic release of our urine. So, step one. We make the urine. It's in the kidneys. We need to get the urine from the kidneys to our urinary bladder. And there's a special tube that does this called the ureter. On lab exams, thinking of ureter versus urethra versus uterus versus urinary bladder, because the urinary system and the reproductive systems are always paired with each other in lab. Make sure that you don't get ureter and urethra mixed up with each other. Usually about 40% of my students do on the lab exam. It's a very common mistake. So as we look at the ureter, it's that tube that's descending from the kidney to the urinary bladder. It's retroperitoneal, so it's posterior to the abdominal pelvic or peritoneal cavity. And they're about 25 centimeters long, so they're about this long-ish. So they're a fairly long tube. And don't want urine flowing backward through our ureters. When you hang upside down, maybe on the monkey bars, or maybe you're lying horizontal and you have a full urinary bladder, and you don't want that urine flowing horizontally back into the kidneys. We physically prevent that from happening with a valve that's located here and here. We have two valves, one for each ureter, and that valve is going to be located where the ureter drains urine into the urinary bladder. Now, as we're looking at the ureter, our ureters have the ability to stretch out. And I'll show you a couple photographs of individuals that have stretched out ureters. When we think of stretching out an epithelium tissue, there's a very key tissue type we talked about last semester with histology, and that's the transitional epithelium. I included a photomicrograph of transitional epithelium up on the screen. When we look at transitional epithelium, look for almost a scalloped edge, a stack of cells that are kind of bulbous. And these cells that are stacked up on top of each other aren't necessarily squamous, they aren't cuboidal, they're just really hard to categorize. A whole bunch of randomly shaped, globular-shaped cells that can be many layers thick, or as we stretch out the tissue, the number of cells stacked up on top of each other is reduced, and we have a thinner layer toward transitional epithelium. As we're looking at the ureter, on the outside, we have the adventitia. The adventitia is the superficial part of the ureter. It anchors the ureter in the body. It makes it so that our ureters don't get tied in a knot, so to speak. Deep to the adventitia, we have the smooth muscle, the muscularis. This smooth muscle, or muscularis, of the ureter helps, through peristalsis, to push urine down into our urinary bladder. It's also worth emphasizing that the peristalsis associated with this layer, this muscularis, also makes it very difficult for bacteria to swim upstream into the kidneys. Occasionally it happens. Occasionally a UTI, or urinary tract infection, results in bacteria getting into the urinary bladder, and from the urinary bladder swimming up into the kidneys. But thankfully, that's a very rare event, because that is a very dangerous thing when we have a bacterial infection of the kidneys. And then that inner lining of the ureter is the transitional epithelium, which I've already talked about. And that transitional epithelium, in addition to the smooth muscle of the muscularis, is very stretchy. As we're looking at the ureter, the lumen itself, so the opening, the hollow space inside the ureter, is very narrow. And this very narrow lumen allows for not only the urine, it also allows for the urine to stretch it out as well. So we can stretch out the lumen slightly with that transitional epithelium as we have a buildup of urine with a peristaltic wave. Next, we're going to come up to the urinary bladder. And as we're looking at a urinary bladder, I'm making it a point to say urinary bladder. I'm not just saying bladder. We have multiple bladders in the body. We have a gallbladder. We also have a urinary bladder. So note to self on your lab exam this week, if you say bladder, it's incorrect. You need to say gallbladder, because we have the digestive system on our lab exam. And then conversely, when we have the reproductive and urinary, our last lab exam, you need to say urinary bladder and differentiate those bladders from each other. So the urinary bladder, to be paraphrased, is a big muscular bag. It's just a bag of muscle, or a bag made out of muscle. This is, I think, kind of gross, but kind of cool all at the same time. Back before we had nice waterproof plastic bags, if you wanted something that could hold fluid, a lot of times you would harvest the urinary bladder that you butchered and use it to ferment wine, or take the use it in the urinary bladder and then ferment it to make wine, or you could use it to curdle cheese or milk into cheese. The same is used for the stomach as well, as a very convenient waterproof bag that was readily available. So we're looking at the bladder. The urinary bladder is going to be in the abdominal pelvic cavity, or the inferior portion, the pelvic portion of the abdominal pelvic cavity. It's going to be deep down in our pelvic girdle. And we're going to have a couple layers to our urinary bladder. We have a parietal peritoneum on the top, and then we're going to have a different connective tissue around the borders. So between the top and the sides of the urinary bladder, we have two different kinds of connective tissue. where we have a parietal peritoneum versus the fibrous adventitia. Fibrous adventitia is on the sides, and then the parietal peritoneum is on the superior margin of the urinary bladder. I don't necessarily know why, but the layers of the smooth muscle of the urinary bladder have been given a special name. To me, it's just another muscularis layer. We have some opposing or crisscrossing smooth muscle fibers. The special name that's been given to this muscularis layer, though, is the detrusor or detrusor. But, it depends on where you were taught, how you pronounce it. These layers of smooth muscle that make up the urinary bladder can stretch out as we fill the urinary bladder, and then when we void the urinary bladder, when we go to the bathroom, they contract and help us to drain urine out of the urinary bladder. Lining the urinary bladder, we have another transitional epithelium. So the ureter has the transitional epithelium. The ureters can stretch out. The urinary bladder also has that same transitional epithelium in it. The urinary bladder can also stretch out just like the ureters. In addition to having stretchy tissue lining the inside of the urinary bladder, we also have folds. And these folds can be spread out as the urinary bladder is expanding. We have rugae of the urinary bladder, just like we have rugae within our stomach that allows for our stomach to expand as well. So as we're looking at this figure, you can see those folds, those rugae, on the superior portion of the urinary bladder. But when we look at where the the ureters enter and where the urethra exits, we can form a triangle. And this triangle does not have any rugae associated with it. We don't want any rugae in this area because we want the smoothest, fastest flow of urine possible. Ultimately, it's going to be kind of like the drain in the bottom of a shower. So we're going to have a smooth, sloping surface, all channeling the urine towards the drain in the bottom, the urethra. This area, without any rugae, is known as the trigone. Tri for, for a triangle. And I'm not sure why we have gone as a suffix, a root word at the end. That one, I'm not 100% sure on. Now, as we're looking at the urinary bladder, for a typical adult, we can typically feel like we need to urinate when we have about half a liter of urine or a pint of urine in our urinary bladder. Occasionally, you can hold it, and if you're really good at holding it in, you can get up to 700, 800 milliliters, or almost 2 pints or almost 1 quart of liquid in your urinary bladder. For reference, it's like an entire coffee cup full of urine, or at least this coffee cup. So we have the ability to stretch out our urinary bladder even more. There are some individuals that have great voluntary control over their urinary bladders, and they've been, unfortunately, able to hold it in so long that their urinary bladder popped like an overinflated water balloon. And then they died a couple days later from sepsis of their abdominal pelvic cavities. There's a really interesting story associated with that. Not Galileo, Kepler, I want to say, and how he was drinking a lot of wine. Kepler is one of the guys that helped prove the heliocentric theory of the solar system. He was drinking a bunch of wine at his patron benefactor's table, and at that point in time, it was very rude to get up and go to the bathroom. So instead of offending the person who paid his paycheck, he sat there and had his urinary bladder pop instead, and died a couple days later. Now, should you ever hold the urine in your urinary bladder that long? No, not. If you have to go to the bathroom, go to the bathroom. If you don't go to the bathroom, if you're one of those individuals that's very prone to just holding it in as long as possible, you're at risk of developing kidney stones or renal calculus. A renal calculus is technically known as a kidney stone. And there are other factors involved as well. Urinating a lot, going to the bathroom frequently is the single best thing you can do to reduce your risk of kidney stones. To go to the bathroom frequently, you should drink water. Make sure you drink at least a couple glasses of water a day so that you can flush liquids through your urethra, your ureters, and your urinary bladders. Depending on your diet, maybe you live in Wisconsin and you eat lots of cheese and dairy products. If you eat lots of cheese and dairy products, you may have excessive amounts of calcium being dumped into your urine, and you can have a kidney stone that's smooth and rounded and made out of calcium. Maybe you are eating a diet that's prone to producing uric acid. So you're eating food that has lots of nucleic acids in it. In those situations, you can have a uric acid kidney stone develop. Those uric acid kidney stones are by far the worst kidney stone, or the worst renal calculi to get. Here's an actual photograph of one. To give you an idea of the size, it's about the size of a pea. So imagine something about the size of a pea traveling through your urinary system, and it's covered in jagged, sharp edges. Of all the urinary stones that you can develop, the uric acid kidney stones are the worst. They are excruciatingly painful to pass. I think I told you earlier, either this semester or last semester, I've had a couple students who gave birth without anesthesia, so they were all natural with their birthing process. And they've also passed a kidney stone. And they've assured me under no uncertain terms, giving birth is a walk in the park compared to passing a kidney stone. I'll take it from them, though. I haven't given birth, so I don't have a frame of reference. Now, these kidney stones are going to form up in your kidneys, hence the name kidney stones. Particularly, they form in the renal pelvis of our kidneys. And the renal pelvis branches out to major calyces. Those major calyces branch out to minor calyces. It kind of looks like the antlers of a deer when you look at the branching pattern. And an old school name for deer is stag. Occasionally, you have a staghorn caniculus develop, or calculus, or a calculus, or a kidney stone, that fills the renal pelvis, the major calyces, minor calyces. These are, to me, I almost did staghorn calculi as my calorie topic, because they just give me the EBGBs. The idea behind this is that the kidney stone has grown so large, it completely blocks all urinary flow from that particular kidney. If you have a staghorn calculi, your kidney is toast. And the fact that this individual had 2 staghorn calculi makes me think that this may have been a post-mortem x-ray. I wasn't able to verify that for sure. But, I mean, if you can't filter your blood, if you can't remove toxins from your bloodstream, you're going to die pretty quickly. To give you a frame of reference, this staghorn calculi is next to a ruler. So we have 1, 2, 3, 4, 5, and at the bottom of the screen would be 6 inches. So a kidney stone the size of your palm clogging up the kidney. Now, this is the extreme example that hopefully you never encounter somebody who's had one of these. Most kidney stones aren't, or renal calculi aren't this bad. So to get rid of them, drink lots of water. If you drink lots of water, you'll produce more urine. A higher flow rate of urine will help push the kidney stone out. If drinking more liquid doesn't work, you can use a pH treatment. These kidney stones are made of typically basic compounds or acidic minerals. So depending on what has formed the kidney stone, you can alter the pH of your urine by your dietary patterns and help to dissolve that kidney stone in the urine. If drinking more water or altering the pH of your diet doesn't work, there are other options. We can use ultrasound, or a form of kidney stone with sound waves, and break it up into tinier pieces that are easier to pass through the ureter, the urinary bladder, and urethra. Or if it's a particularly large kidney stone, it can be removed endoscopically, or it can be removed surgically, where you are cut open and it's pulled out. For the record, staghorn caniculi have to be removed surgically. There is no easy way to get those out. As we look at the urethra, you can think of this as the in-floor drain of your shower. So the urethra is right in the middle of the trigone. It's right in the middle of the depression of the urinary bladder. And the urethra ultimately carries the urine out of our bodies. And this is where we have some gender-specific differences. Females have a much shorter urethra. Males have a much longer urethra because, guys have penises, females don't. The female urethra is quite short, and in terms of where it's located, it's going to be just anterior to the vagina. So if we're looking at the vulva, or the female external genitalia, the urethral orifice is going to be in between the vaginal orifice and in between the clitoris. So it's going to be on the anterior half of the vagina, or excuse me, anterior half of the vulva. And as we're looking at the female's urinary bladder, we have an external urethral sphincter. This external urethral sphincter is made up of pelvic floor muscles. These pelvic floor muscles are a combination of both smooth and skeletal muscles. So we have a combination of muscles that we can voluntarily control and muscles that we cannot voluntarily control. A lot of times during the birthing process, that skeletal muscle of the pelvic floor is torn. Sometimes it's sliced intentionally. That's called an episiotomy. That makes it easier for the baby's head to fit out of the vaginal orifice. Sometimes it's torn. Regardless if it was an intentional or unintentional severing of the tissue, the end result is that a lot of women that have given birth, or a lot of mothers, have had damage to their pelvic floor and have a harder time keeping the urine in. They have partial incontinence. There are exercises done to help with this process. I believe they're referred to as Kegel exercises. And this is one of the, mostly it just involves taking a medicine ball in your knees and squeezing your knees together a lot with a medicine ball in the middle. And then also just kind of, you can't really see it, but that sensation you get when you're doing the Valsalva maneuver, and you kind of contract all the muscles down here at the same time. Squeeze the medicine ball, do a Valsalva maneuver, and do it, every morning and every night. And you can regain some of that function. The male urethra, though, is a lot longer than the female urethra for obvious reasons. Another thing worth emphasizing is, gentlemen, you are anatomically able to hold the urine in longer because you have double the number of sphincters. Females have an external urethral sphincter. Notice there's no internal urethral sphincter on this figure. Gentlemen, you have an internal urethral sphincter in addition to your external urethral sphincter. So when you're complaining about maybe your little sister, your mom, your girlfriend, or your wife, why do you have to go to the bathroom? The reason they have to go to the bathroom more frequently. So be sympathetic. Now, when we look at the male urethra, the two big differences. Number one, it's longer. It's longer because it has to travel through more structures. And we break up the male urethra into three portions. The first portion is the prostatic urethra. The prostatic urethra is the portion of the urethra that travels to the prostate gland. The prostate gland is immediately inferior to the male's urinary bladder. It's about the size of a walnut. As men age, the prostate through hypertrophy. The prostate enlarges, and that's a normal part of the male aging process. It's also a common form of cancer. Prostatic cancer, or prostate cancer, is the second biggest cancer killer in males, second only to lung cancer in males. So, gentlemen, you need to be more sympathetic to the ladies because they have to go to the bathroom a lot. Ladies, you need to be more sympathetic to the gentlemen. when they spend forever in the bathroom trying to go to the bathroom, because as that prostate is enlarging and getting bigger, not only does it press upward into the urinary bladder, it also pinches off the prostatic urethra. And, candidly, I'll admit I've seen elderly gentlemen in the public bathrooms, and they've been standing there for 5 minutes trying to urinate at the urinal. And they struggle because they have a very low fluid flow rate from that enlarged prostate. So there's the first portion, the prostatic urethra. The next portion is known as the membranous urethra. And this membranous urethra is present in both males and females. It's a portion of the urethra that travels through the urogenital diaphragm, or the pelvic floor. For males and females, the membranous urethra is going to be surrounded by the external urethral sphincter. It's worth emphasizing that in males, there's that internal urethral sphincter right up here, and that internal urethral sphincter is going to be made up of a widening or thickening of the urinary bladder as interfacing with the prostate. And then we come to the spongy or penile urethra. In terms of definitions, or like the starting and ending point, once the urethra has entered into erectile tissue, it's now going to be recategorized from the membranous urethra to the spongy urethra. And I like the term spongy urethra because the erectile tissue is very spongy in its appearance. Penile urethra works pretty well for a name because it's also the portion of the urethra in the penis. So this distal portion of the urethra is the spongy or penile urethra. Occasionally, we can have some things go wrong with our urinary systems. If we have inflammation of the urinary bladder, that is known as cystitis or cystitis. Females, because they have exceptionally short urethras, are very prone to having bacteria and other microorganisms to their urinary bladder. These urinary tract infections, or UTIs, or cystitis, are often going to be aggravated or the direct result of vaginal intercourse. And as the penis is moving up and down into the vagina, that penis is going to be rubbing against the urethral opening and pushing the mucus of the vulva up into the urethral opening and pushing a lot of microorganisms into the female's urethral opening. This is just a natural consequence of intercourse. Females have a built-in mechanism to help protect against that. Most females will have this instinctual drive to urinate after having vaginal intercourse. And this instinctual urination that occurs after having vaginal intercourse, functionally, is a really good thing. It helps to push those microorganisms out of the urethra to keep them from getting into the urinary bladder. If we have inflammation of the renal pelvis, pyelitis, that's a problem. Because at that point, the bacteria have made it into the urinary bladder. They've traveled again upstream through the ureters, and now they're into the renal pelvis. When we look at a UTI or cystitis, as it's just technically referred to as, most of these resolve by themselves. Just drink a lot of water, drink a lot of fluids, and if you upregulate the amount of urine being produced, you'll flush the microorganisms out and relieve yourself from that infection. Once you get the microorganisms up into the renal pelvis, it's a much more difficult process of flushing them out because these are typically going to be highly motile microorganisms, either with multiple flagella or with many cilia, helping them be able to swim against the current. And occasionally, in very serious situations, those microbes can make it all the way into the nephron itself. So they swam upstream into the renal pelvis, then they swim upstream through the collecting duct into the distal convoluted tubule, the nephron loop, and they just keep swimming upstream. If they make it all the way to the renal corpuscle, they're now going to be getting to a capillary bed that's highly permeable and highly porous, and they have easy, direct access to the bloodstream and the ability to travel to the rest of the body almost instantaneously. So pyelonephritis, or a bacterial infection of the nephrons, is a very big deal. So let's talk about how we urinate. As we are filling our urinary bladder, eventually we need to have that episodic event. We need to get the urine out of the urinary bladder. We are going to first fill the urinary bladder. As we're filling it, we can't contract the detrusor. We will relax the detrusor, the urinary bladder fills up, and then it starts to stretch out. As we're filling the urinary bladder, the sphincters, either internal and external, or just external, depending on your gender, are going to be tightly closed. Eventually, though, it is stretched out. We're going to have a change in our autonomic nervous system. Initially, when we're filling it, the autonomic nervous system causes the relaxation of the detrusor and the constriction of the urethral sphincter. The external urethral sphincter, which is worth emphasizing here because both males and females have the external urethral sphincter, is your voluntary control. So it's primarily made of skeletal muscle. This voluntary control, though, of the external urethral sphincter can be overridden by our autonomic nervous system if your urinary bladder has been overinflated with urine. The technical name for urinating is micturition. So when you are voiding the urinary bladder or excreting urine from your body, that is technically known as micturition. The micturition reflex is this reflexive voiding of our urinary bladder as it's stretched out. To sense how full our urinary bladder is, we have stretch receptors built into the urinary bladder. And those are going to send signals to the spinal cord, through the afferent branch of the peripheral nervous system. As we're looking at our urinary bladder, a lot of times you want to go to the bathroom before you go on a long trip. Because it's a pain in the butt to pull over and go to the gas stations frequently. So while you're at a gas station, you go to the bathroom, you force yourself to urinate even though you don't need to. In those situations where you're voluntarily urinating, you are going to perform that salvo maneuver we talked about earlier. We breathe in, clench and bear down, and as you're doing that and constricting these abdominal pelvic muscles, you are going to compress the urinary bladder. Compressing the urinary bladder activates those stretch receptors and prematurely triggers the micturition reflex, even though your urinary bladder is not full. So let's end our class period with one last review question. Say select all that apply, not selection all that apply. So select all that apply. Which of the following statements about the countercurrent exchange system are correct? I'm going to give you an extra minute and a half on this question. It's kind of a doozy. So talk amongst yourselves, flip back, look at the fluid flow directions of ascending and descending limbs, and then the movement of water in and out of the ascending and descending limbs of both the nephron loop and the vasa recta capillary bed. About 45 seconds left. Based on the murmuring in here, I think maybe we don't need any more time. I'm going to end it in 10 seconds. All right, 5 seconds. Please submit your answers. All right, we're done. So, as we are looking at, can I zoom in and out? Excellent. As we're looking at these statements, the first statement, statement A, is correct. The medulla has a higher osmolarity than the renal cortex. We had that saline gradient we talked about. The ascending limb of the nephron loop, the thick segment of the nephron loop, is going to have active transport of ions through the extracellular fluid. That was a correct statement. As we look at urea, urea leaves the collecting duct and enters into the thin segment of the nephron loop. That is another correct statement. And then finally, the descending capillaries of the vasa recta lose water to the extracellular fluid as those capillaries, as the blood goes to higher and higher saline concentrations within the renal medulla. So that is all for today. I will see you Thursday.